Much, Laura. I work in tech, so if I'm not talking the slides, then I'm not doing my thing. Let me just confirm these are showing up properly.
Yes, looks good.
It's the full view, not the preview.
You may want to change the display
Sure.
settings. That's the speaker view we're seeing.
Thank you. All right, well, hello everyone. I'm Jena Goodridge, and welcome to the 4th bi-monthly virtual Heart Center update. We're so excited to be here with you today to learn more about heart failure and the VADs program, and to talk with Dr. Penny, Dr. Calderon, Dr. Adachi, and Dr. Dreyer. So we have a full house today. Please feel free to turn on your cameras throughout the presentation. We want this presentation to, although it's a virtual update, we want it to be both intimate and informal. So please feel free to jump in if you have a question. Also, we'll be reserving at least 20 minutes towards the end of the presentation for Q&A. So you can either ask it then, or if you'd prefer to type it into the chat, we can ask it for you. Okay, and as we noted, the session is being recorded. So hello, I am Jena Goodridge. I'm here to share just about 5 or 10 minutes of our family story. This is me and my husband. We are the parents to Emily, who's 17 years old. She's our heart warrior, and Zach, who is 15 and heart healthy. I work at Dell Technologies. I've been married to Tim Goodridge for 23 years. He's an anesthetist here locally in town, pictured there. He wanted to join us, but he was on an airplane coming back from a conference in San Diego today. We've got 2 dogs, Sydney and Lex, and 1 snake. And we live in Round Rock, which is just north of Austin, Texas. We did spend 10 years in the Woodlands from about 1999 to 2010. And then we moved to Round Rock in 2010. And so what I want to share with you today is a little bit about our story, as well as maybe the perspective of a mom with a kid who's a little older. We were hoping to get Emily to join us today. She's obviously in high school right now and wasn't able to step away. So here's a picture of Emily. She's a high school senior. She's currently working on her college applications to apply to schools in Texas, Maryland, and the Northeast. She wants to be an ER nurse, so I'm really excited about that. She also wants to be an EMT while she's in college, and she's also interested in fashion design. She works part-time at farmers markets on the weekend, and she enjoys hanging out with friends. I do wish she was doing more college application work versus hanging out with friends, but that's, you know, the regular teen dilemma, I guess. So here's our heart story. Here's Emily when she was about 5th grade. For the life of me, I tried to find some older pictures, like when she was in the hospital, and I just couldn't. So she's in 5th grade here. She was born in 2003 in the Woodlands. She was diagnosed with a congenital heart defect at birth. So when she was nursing, the lactation consultant noticed that she was a little bit gray, and the pediatrician came, realized there was something, not quite right. So she was transferred down for observation at Memorial Hermann Children's. We didn't know about Texas Children's yet, and my husband worked at that time for Memorial Hermann, and she stayed there for about a week. Nothing, no surgical interactions were done. We got a second opinion when she was about 6 weeks old at Texas Children's. Our pediatric cardiologist is Dr. Altman, and we've been with her the whole time and absolutely love her. Emily was diagnosed with Schoen syndrome, which is a collection of left heart defects. And she had her first open heart surgery in 2004 at about 12 weeks of age with Dr. McKenzie, who we also absolutely love. All right, so for those of you who don't know what Schoen syndrome is, because it is a little bit of more of a rare heart defect, I don't actually know very many moms with kids who have Schoen syndrome. As I mentioned, it's a collection of left heart defects. So the first thing that you see is a coarctation of the aorta right here. So this is like a little pinching. And so what Dr. McKenzie did was cut out that pinching and then advance the aorta together and stitch it up. She also has mitral valve stenosis. So obviously the left atrium of the left ventricle, the mitral valve is right in the middle there. And I meant to say at the beginning of this part, I hope the doctors don't grade me on this presentation because I'm sure there's something, probably not 100% right. So there's the valve, and Emily's valve, her leaflets were like really sticky and thick. They had like this calcified stuff on it, and her muscles that pull the valve down didn't really work very well. And she also had a very, very, very small mitral valve, so small that mechanical valves wouldn't even fit. They didn't make a valve that was small enough. So Dr. McKenzie went in there and cleaned that up, made that a little bit bigger. She also has a subaortic stenosis, which means right in front of the aortic valve here, there's like little bits of muscle that make the blood flow turbulently through that valve. And then she also had a PDA and a VSD. So that's kind of Shones in a nutshell. Here's a picture of Emily here. This is a day she was getting a cardiac MRI. So obviously she's a little older past her surgeries, but before her first surgery, the guidance we were given by cardiology was just don't let her cry for more than 5 minutes, which, as you can imagine, with a newborn, totally stressful. We really became a master at hand sanitizer and hand washing way before it was pandemic cool. We were just trying to keep her really healthy and keep germs out of the way so that her body could focus just on getting ready for the surgery and healing after the surgery. So as I mentioned, Emily had her first surgery when she was 3 months old. When she was about 1, we decided it was time to have another baby, add another baby to our family. Sadly, our second baby was diagnosed with a congenital heart defect that was not compatible with life, and she was stillborn at 20 weeks gestation. And I would say, obviously, a very sad time in our lives. But the gift that I'm able to take now in having so much time between then and now is that that experience really just gave me so much empathy for other people that I didn't have. And that's something that really just still sticks with me today. And then to complete our family, we adopted our son, Zach, who I think you saw on the first page, from China when he was an infant in 2008. And after Emily's first surgery, we would travel to Houston a couple times a year to have her monitored after we moved back to Austin. At age 5, we thought it might be time for another surgery. We got that tested via cath. Wasn't time yet, so we were really thankful for that. We moved from the Woodlands to Round Rock, as I mentioned, in 2010. And then we continued several years going back to Houston and Texas Children's for visits. We also had a local cardiologist here just in case of emergency. At the age of 12 in 2016, it was time for surgery again with Dr. McKenzie to improve that mitral valve stenosis and the subaortic stenosis. I know it's hard to believe, but she was up and walking around the next day, eating pizza in the ICU. We have pictures of that, which I had wanted to share with you, but couldn't find. And I don't jump lightly from oh, she had surgery and then she was up the next day, because we all know that's not really how it works. But I just wanted to share that with you because, as an older kid, or when she had her first surgery, it was terrifying because I thought, oh my gosh, I don't know anything about this. It's going to be terrible. And I'm really scared because I don't know what's going to happen. And then when it came to the second surgery, I was terrified and scared, but because I knew what was going to happen, because I knew what the recovery was going to be like. And that's something that also stuck with me a lot. And then just a fun fact, the first post-surgical ICU nurse we had for the first surgery and the second surgery was the same nurse. His name is Abraham Godley, and you can't forget someone with a name like that in such an important part of your life. So then what's next? Well, Emily does annual checkups at TCH. We were just there about a month ago. And as your kids get older, there's a really wonderful transition program where social workers meet with your child and help them learn how to talk about their congenital heart defect and how to talk with doctors like their primary care physician, and things to look out for and things to do and not do, and just really take care of themselves as they move into the next phase of their life and they get a little older. And then hopefully, Emily will go to college next year, which is both exciting and terrifying. So that's all I wanted to share with you today. I do appreciate your time. Happy to answer any questions towards the end. But at this point in time, I would like to turn it over to Drs. Calderon and Penny to introduce our guests.
Good morning, everybody. Jenna, thank you for such a lovely story. I will tell Godley that you mentioned. I saw him this morning, and I'll tell him, I'm sorry, there's a lot of feedback here. Headphones, maybe.
That'd be great, thanks.
So we will tell Godley that that you mentioned him. He's a wonderful guy, and he's still working with us. So I'm here with my friend, Dr. Chris Calderon, and we are really looking forward to this morning to introduce our heart failure transplantation leaders. One of the big jewels in the crown of our heart center is our heart failure and transplantation program. And it is a world-class program run by world-class leaders. What we like about it particularly is that it's completely dependent on the ability of a team to work together. So this is real team ball. And so Chris and I are really honored to work with our two speakers, and Chris will start by saying some words and introducing our first speaker.
Great. Thanks. Hi, everybody. And thanks for such a nice discussion beforehand. I hope when we have times for question and answers, I want to talk with you a little bit more about what you described as the fear of the unknown in your first operation, and then the fear of the known in your second operation, because we need to work on making both of those become a little bit less, at least as much as you can do with the, within the parameters of worried parents. But we'll be working on that. Let me, if I can, though, shift gears pretty quickly, and that is introduce one of my friends and colleagues, and that's Dr. Adachi, who will be speaking to you from the surgical perspective. Dr. Adachi is actually very shortly going to be involved in a surgical procedure, and I think the timing is going to work out just right, but he may have to leave a little bit early in the program. That being said, he's one of our members of the surgical team here. He is a world-recognized leader in the development of pediatric ventricular support devices, and he is head of our cardiac transplant program. He is really a thought leader in the entire community across the country and internationally in terms of novel ways of supporting children and infants with failing hearts. He's worked with industry to develop new products, and he may be talking to you about this. He regularly speaks at international venues with hundreds of publications, talking about some sometimes extremely provocative ways to challenge the way we've been able to support failing hearts in the past and develop new ways in the future. So with that, I'll turn it over to Dr. Adachi.
Hello, everybody, and thank you very much for your time. I'm really excited about this opportunity. I thought Dr. Dreyer is going to give a talk, and I follow. But Jeff, are you okay with me?
Yeah, no, that's fine. I realize that you're under a bit of a time crunch, and so I said earlier that it's fine for you to go first. I can work it either way. Actually, the transplant. Actually, I'm going to do a transplant, but there's a little bit delay, so I can follow you as scheduled. But maybe actually
Okay.
Better flow.
Well, that makes more sense then. So
Yeah, sure, absolutely. And yeah, so Icky is going to do it, as you said, a transplant very shortly, but there's a little bit of a delay. So good timing in terms of the procedure he's doing this morning. So I am thrilled to introduce the other member of this leadership duo, and that is my friend William Jeff Dreyer. Jeff is the head of our heart failure transplantation program here from a cardiology point of view. Jeff has been at Baylor Texas Children's Hospital since he was a fellow in cardiology, and that was from the mid-80s. And so he really has his fingerprints on every aspect of the evolving heart failure transplantation programs at Texas Children's Hospital, of which we're so proud. Jeff is a humble guy, but one of the things I would like to mention is that just recently he was given a Master Clinician Award from Baylor College of Medicine. This is an award that true world leaders in terms of clinical care get from Baylor. It's a very, very, very highly sought after recognition, and I am thrilled that Jeff's contribution has been recognized with a Master Clinician Award. Chris and I and Nikki and the rest of us will continue to try, and maybe one day we will achieve that as well. So welcome, Jeff, and I'm so proud to work with you.
Well, Dan, thank you very much for that very kind introduction, and I'm thrilled as well to be here today and to have the opportunity to talk with each of you. And I do have just a few slides to share with you, and so I'm as some of us that are a little older, as it turns out, we're pretty technically challenged, but I'm going to try and share my screen and bring up my slides. So bear with me just a second. Let me see if I can make this actually happen. So let's see if this works. Hopefully you can see this.
Yes, we can, Jeff.
Okay, great. Our program is integrated, and we between the patients that we see for heart failure as such, as well as those patients with heart failure that need more advanced therapies. And it's those advanced therapies, in fact, that we're really going to be talking about today. I wanted to share a little bit with you about our program in cardiac transplantation. And Dr. Adachi will, as already mentioned, be talking to you about our ventricular assist program, our mechanical circulatory support program of the heart, which makes all the difference for us in some of our patients, as far as we would say, bridging them to transplant is concerned. And just to give you a little bit of a historical perspective, we consider the inception of our heart transplant program at Texas Children's to be November 1 of 1984. And on that date, Dr. Denton Cooley and Dr. Bud Frazier performed Texas Children's first successful heart transplant in an 8-month-old child with a condition called dilated cardiomyopathy. She was in heart failure and there was really no other therapy for her. And the surgery went well. I happened to be a first-year fellow at that time and took care of this beautiful doe-eyed little 8-month-old pre-transplant to some extent. And as I said, her transplant was successful. At the time, she was the youngest patient in the country to undergo a successful cardiac transplantation. It was national headline news at the time. And it's really from those beginnings that the program started. And in fact, it has grown considerably over the course of time. And it's some of that growth that I wanted to share with you now just a little bit. So I'm going to try and advance my slides here. And this is this actually looks at the last 15 years, dating back to 2006, and the number of transplants that we performed per year. Now, according to the UNOS is the United Network for Organ Sharing, which is really as stated, the national network of transplant, adult, pediatric, all the different solid organ transplants that they monitor and keep track of. But you know, for the UNOS definition of a large pediatric program is one that does more than 10 transplants a year. And so even if you date back to 2006, you can see that we would still be considered a large program, but we were averaging about 15 transplants a year up until 2014, and then the program took a big jump. That year was sort of our benchmark year, in which we performed 32 transplants, and then you can see what has transpired in the last 7 years through 2020, and that average of 15 jumped up more to an average of about 27 to 28 per year. And as I'll show you on the next slide, in fact, that has made us the busiest program in the country over that time frame. So this kind of shows that cumulative number of heart transplants performed and the different centers that have performed those transplants. So Texas Children's is first over that period of time. And you can see, I won't necessarily mention by name, I will point out that fourth on that list is our friends in Dallas at Children's Medical Center. But there are any number of children's. New York Presbyterian has always been very big. This is Columbia Medical Center in New York City, of course. And then any number of programs across the board, as you can see. Now, to date, including these transplants and the ones that we have done this year, we've reached a total volume cumulatively over the years of our program of 502 heart transplants. And that this is unofficial, but I believe there are only, including ourselves, 4 programs nationally that have reached that benchmark. And some of them are from work that they did a number of years ago and not so much now. One of the programs is the New York Presbyterian. The other 2 are Loma Linda and Children's in Colorado. But so it means obviously that we've been a large volume program now for a number of years, and we've sustained a very significant growth. Just looking a little bit more closely at this just happens to be the calendar year 2020. And you can see that we led the nation in the number of transplants performed at that time as well. And again, the names are sort of the same across the bottom. They're in a little bit of a different order. Obviously, there's some ebb and flow from year to year, but the same sort of programs show up. And you know, Dallas is here in 3rd place, if you will. And in tabular form, as opposed to those bar graphs, you can see the volumes for 2020. I'll point out to you that there were a total of 461 pediatric transplants that were performed, and that's pediatric heart transplants that were performed across all centers in the United States last year. And that's about 1/7 the number of transplants performed in the adult population. And you can see then the rank order listing. Now, in fact, we do a few patients here that are considered adult. That's because UNOS's definition of adult is anyone that's 18 years of age and greater. And so we have 1 or 2 patients a year that we transplant that exceed that 18-year-old threshold. And there is some work going on that suggests that we may do some more as our adult congenital heart disease program grows. But again, just a sense of the kind of numbers that we're dealing with here. But, you know, volume is one thing. And what's really important is not just the number of transplants that you do, but the kind of outcome that you have. And so this is data that is reported by the SRTR, which stands for the Scientific Registry of Transplant Recipients. It is a statistical arm of UNOS, if you will. They keep track of all centers across the country. As I was mentioning, all different kinds of solid organ transplants, whether that's heart, lung, liver, kidney, what have you, and adult and pediatric. But, and they report every 6 months. And this is their most recent reporting, which was in July of this year, July of 2021. And this is looking at 1 year survival. Now, what they typically do is take a 30-month snapshot of the programs, if you will, and they're always a little bit delayed. They were, in fact, a little bit more delayed because of COVID this past year. So this just includes a snapshot of January 2018 through March of 2020. But the good news is for our program is that our survival was during that time 100%. And that's that's all of our pediatric transplants and our adult, although our adult numbers are obviously considerably smaller. Now, they also come up with, they have a formula from which they calculate an expected survival for your program. There are a number of variables that enter into that formula to come up with some expected survival. And as you can see, it's about 93% for us. And we exceeded that, having had 100% survival. And well, we can't really do better than that. And now we can't help but have some attrition. It does happen. If you look at our 3-year survival statistic, and this in fact actually addresses a different cohort of patients because they have to have survived at least 3 years to be included. But our survival of 92% is actually considered very good, and you can see that it also exceeds our expected.
Dr. Dreyer?
Yes.
Could you just quickly explain the difference between graft survival and patient survival?
Yeah, that's sure. And in this particular instance, obviously, it's hardly different. You can have a circumstance where a patient survives where the graft may not, in that you've transplanted someone and the donor organ fails. If that organ fails, you can retransplant that patient. So conceivably, you can have a patient who survives receiving a second graft where the graft itself has been lost. And so that's the real difference between the two. But we just don't lose grafts really in these kinds of time intervals, really. So to look at graft or patient survival in this time frame is virtually the same. But that is in fact the difference between the two. And so what I wanted to show with the next slide, and this is, I think, perhaps the most important slide that I can show you. And this is from the SRTR as well. And this is for pediatric age patients less than 18. And this is transplants performed from January of 18 through June of 2020. The circles represent the different pediatric programs transplanting patients. The x-axis here represents the volume, the number of transplants performed by that institution during that particular time interval. And then the y-axis represents what is called the hazard ratio, or you're looking at your observed survival versus your expected. And so the lower your hazard ratio, the better your outcome is considered to be. And so this circle, the blue circle is Texas Children's. And so what it really shows you is during that time frame, we were right at the top in terms of the number of the volume of transplants performed, and we had the best survival of any of the programs in the country. And so I'm very proud actually of this result. Of course, you know, survival is not the whole story. It's the grossest measure we have of outcome. It doesn't talk about quality of life. It doesn't talk about mental health issues, other comorbidities that may happen in terms of infection or other organs, injuries, and that sort of thing. It's just, did you survive your transplant or not? But it's the easiest one to track, and so it's the best indicator that's really available. Although obviously it doesn't tell the whole story. And then actually I wanted to end, and I will use this as a segue into Dr. Adachi's talk. You know, it's fine to look at some bars and dots and numbers and that sort of thing, but it's really helpful to put a human component to this. And so Dr. Adachi is going to talk about VADs. And one of the VADs, or ventricular assist devices that we have used, is the hardware device. As I said, Dr. Adachi will, I'm sure, go through that with you in more detail. But this is a photograph that I had, and there's no HIPAA violation here. Everybody had signed releases for this sort of thing. But this is the very first 5 hardware patients that we supported. And realize, of course, if they hadn't been supported, probably they wouldn't have made it to transplant if that's what they needed. And they may very well have died without this kind of, more likely than not, they would have died. But I wanted to share with you, this young lady was the first to receive the hardware device. It's more than 10 years. She was fine with her device. She wanted no other therapy. She still has it. She still has that device in place. It supports her. She's gone about her life in a very robust way, and just with what we refer to now as destination therapy, because she didn't want a transplant and her family didn't. This young lady is pretty remarkable in that she's a cancer survivor. So she first had cancer, was treated for that, lived through that, but as a consequence of the chemotherapy that she received, some of that chemotherapy is cardiotoxic, and it affected her heart to the point where she was in terrible heart failure. And we had no real options except to put a device in. We weren't sure where she was going to go, whether her cancer might reoccur, whether her heart might recover, what would happen. But we knew that if we didn't do something for her, she wasn't going to survive. What happened is that we supported her. Her heart recovered while she was on that support. We were able to explant that VAD. She is now a cancer survivor into adulthood with a normal functioning heart and no recurrence of her cancer. So pretty remarkable story. And each of these young gentlemen in front here that received this device served as a bridge to transplant, and they all went on to successful transplantation later. So they all look pretty good in this picture, and that's a consequence of the device supporting them. This is what we were, trying to do with it. They are all outpatients in this picture. That is something that was really quite innovative on the part of Texas Children's and Dr. Adachi. But again, I wanted to put a face to some of the work that we've done and not just statistics. And so here they are. But with that, I'm going to stop and let Dr. Adachi take over. So I have to figure out how to unshare my screen, right?
Am I sharing now?
Yes, you can.
Am I sharing now?
Yes, we can see it. It's not in slideshow presentation. There you
Perfect.
go. All good.
Oh, great. Thank you. So thank you again for this opportunity. And then obviously Dr. Dreyer's talk is a really great summary of how important the heart transplant is in the pediatric population and how the TCH, Texas Children, has been doing in the field. And obviously the heart transplant is a very important treatment option for us. And that has been saving the lives of many children who wouldn't survive without transplant. Obviously, that's considered to be the golden standard treatment. In other words, we don't currently have other options beyond heart transplant. What's going to happen after transplant? And that's what we are tackling very actively now. So as I mentioned, the heart transplant is important, and probably that will give us our patient like 10 years, 20 years, some patients actually 30 years with a graft. But as the data Dr. Dreyer showed earlier, currently the graft survival and the patient survival, they are almost identical because we don't really have the option, good option, once the graft started failing. That's why these two survivals are almost identical. And that's what we want to change. And because of the limitation in graft durability, still, even with a very successful heart failure management, there's a really big gap between the normal population and heart failure population in terms of life expectancy. That is what we want to change. We want to with the artificial heart. This may sound a little crazy, but from the medical and the surgical standpoint, using the artificial heart is not really very difficult. The operation is almost identical because both options, transplant or artificial heart placement, they are both cardiac replacement therapy. Transplant is just with a biological heart. Artificial heart replacement is just with a mechanical heart. Operations are almost identical. We have now very the promising device called BivaCore, which we are working in the laboratory to make it available for actually our patient. Very interesting technology. And particularly over the last couple of years, there has been a real significant advancement in this type of technology, including the batteries. For example, now we see a lot of the electronic car like a Tesla. And for example, Tesla Model S battery can run this type of pump almost more than a year without recharging. So it won't be technically impossible to make a smaller battery that can run this type of device for a couple of days without recharging. It's very possible with the current technology. We are actively working with this type of device development so that we can save our patients who have the problem with a graft. And these are the cows we are currently supporting with this device. The left side cow, he's been living without native heart for more than 3 weeks now. The right one is just got the surgery only a week ago, but they both of them doing well without heart, which is a little crazy. But we are making very significant advancement. And that's important. These are the patients and their families who were in the past or who are currently supported with the ventricular assist device. And the obviously, until their graft start fading, we need to develop the future solution for this patient. So thank you very much for your time. And then I'm happy to take any questions. Thank you.
Thanks, Aki. Thank you, Jeff. And I wonder whether anybody has any questions I'd like to ask of them.
I have a question if no one else has a question.
Thanks, Jenna.
And my question is for Dr. Dreyer and for Dr. Adachi. And it's the same question. That is one of my dogs entering the room now. Behind me. So what is the future of heart transplantation and assistance devices? You know, you mentioned, Dr. Dreyer, in the beginning, you know, it's been decades since our first one there at Texas Children's. And so maybe you've obviously both seen a lot. Whatever the next 10 years going to bring?
Well, I think that a couple of things. And so what I did not emphasize during the time that I was talking is, in fact, that, you know, I was focusing on the positive. You know, heart transplant becomes an option when no other options really exist. But it's not a perfect solution. And as Dr. Adachi was pointing out, the longevity of a transplanted heart, when you provide it for a child, is not really what would otherwise be the normal, natural lifetime of that child if they didn't have their heart disease. And if you look at 50% survival statistically, the so-called half-life, if you will, of a transplanted organ, we're getting better. We're out at 17, 18 years is the kind of number that we quote our families now, which is, you know, and if you look at an era effect, I didn't show that kind of information, but, you know, we're clearly better now than we were previously. So and we do retransplant patients, but statistically, when you look at retransplants, a second transplant doesn't last as long as a first transplant. And a third heart transplant is an extremely rare event. So it's happened, but it's, again, extremely rare. So we will get better with some things like immunosuppression and being able to maintain the organs that we transplant. But I also believe that the real step forward will be made in mechanical support technology, as opposed to improving transplant outcomes. And so the kinds of things that Dr. Adachi are talking about, which sound a little, you know, sort of sound a little Buck Rogers or, you know, futuristic, and in fact maybe they are, but they're very attainable. And I think that the difference maker is going to be that kind of technological advance, as opposed to medical advances supporting a transplanted heart.
Thank you.
It sounds like, I'm wondering if you're saying, whereas before or right now we look at these artificial devices as a bridge to a heart transplant, is the hope that maybe these could be the long-term solution, that it's no longer a bridge, but maybe the long-term solution for patients?
Well, and I believe that to be true, yes. I mean, the devices, my focus was on when, in the brief amount of time I talked about a device, we did talk about it as a bridge to transplant. That is correct. But I think that you're exactly right. I think that not just a bridge to transplant, but then as a solution to, if you will, transplant is something that is potentially on the horizon. I think so.
With those artificial implantations, do you have to do the same amount of immunosuppression as you would an organ transplant? Does the body tend to reject artificial devices?
No.
Okay. So that could maybe possibly be a better solution than an actual organ transplant.
I think it's entirely dependent upon the device and how well the device works. The thing that you face with most artificial devices that are being placed is not immunosuppression, but anticoagulation, blood thinning.
Okay.
And there is some infection problem in terms of, because right now most of the devices have an exteriorized line, but I think that technology will change as well, and that for any monitoring or recharging of batteries and so forth, that the devices will be placed totally within inside the body, and the ability to monitor or recharge a battery will be through the chest wall, through the skin, and that sort of thing. And I should let Dr. Adachi speak to that, because he's clearly far ahead of the rest of us in understanding that technology.
Yes, these are the really great questions, and thank you very much for that. To me, obviously the heart transplant and the assist device or total artificial heart, both of these are very important the tools for us physicians to utilize to give their extension of life to our patients. And both technology or the treatment strategy have strengths and weakness. We need to combine all of these. What we've been doing and what we are becoming good at is, for example, use the assist device in really, really sick patients prior to heart transplant, so that they can get better. In the past, long time ago, the really, really sick patients were getting the heart transplant. And obviously heart transplant itself is a big operation. So if they are not really doing well at the time of transplant, they don't do well with the operation. And then obviously the graft won't do well. But nowadays, as you guys can saw the picture of the patient, they do really well with the device. That's why when they go to the operation for the transplantation, they are very, very well prepared, which is why, for example, our early result 1 year graft survival, patient graft survival 100%, because they are very well prepared. So we are, I hope you guys can see my slide, we are getting better this phase. And also we are kind of extending this phase so that we can delay the initiation of heart transplantation, which is time-limited palliation. That's what we are doing right now. But at the same time, at some point when this heart starts failing, then obviously we want to introduce this type of technology. But the real benefit of heart transplantation, which is biological cardiac replacement, is that actually the implanted graft has the ability to grow as a patient grows. Obviously, small patient like an infant or small babies, they can't really have this type of treatment. But by using the biological heart, actually we can give the opportunity for the patient to grow so that their body will be able to accommodate this type of treatment later on. Or other scenarios, we treat a lot of patients, many patients with very complex congenital heart disease. Their heart structures are very, very different from the normal heart. And then these anatomical variations make the implantation of this type of technology very, very difficult, because this is only for the normal heart, essentially, structurally normal heart. But by using the biological heart graft as an adapter for this type of technology, because the implanting the cardiac graft has a normal structure. So by doing the heart transplant as an interim surgery, then the patient will be a good candidate for this type of technology, even their underlying condition was complex congenital heart disease. So we are actually seeing these treatment so that, you know, as a combination, we can give the extension of life to the patient. I hope this kind of explain what we what I'm thinking.
Yeah, that was really helpful. And it's interesting too to think about, like you were saying, someone with a single ventricle or a complex congenital heart defect, it becomes a little bit more of a complicated process. So that makes sense. So
that's what essentially we are kind of, you know, trying to see the heart transplantation as a reversed bridge to artificial heart, which is essentially a paradigm change. But that's the paradigm change actually we want to introduce from Houston.
Yeah, and a point that I would like to make on top of that. And so when I talk to families about transplant now, I talk to them about buying time. And buying time in that, you know, yes, we know a transplant isn't going to last the full and natural lifetime of the child, but if we give them 10 to 20 years with that transplant, it's buying time to allow this technology that is still under development to mature and to become available. And so transplant is important in that regard as well. It's and so yes, it's a bridge. It's a reverse bridge. It's what we were just talking about. But you know, it's buying time for those patients and those families with to allow them to grow, as Dr. Adachi said, which is a very important point, and to allow this this new technology to mature.
So then I would think too, just getting the word out and making sure people understand how important it is and how we're all on a timeline to get these things developed for these kids. I think that becomes really important. Mm-hmm. So how much does TCH, how involved are y'all in the creation of these devices? I know TCH isn't necessarily a research-based hospital, it's a teaching hospital. How much do y'all participate in creating these devices, or is that done in a different place, in a different way?
We are playing a very sort of key role in this type of device development. The device, the assist device, currently being tested in the clinical trial in the US and Canada was tested. We tested in the laboratory for 5 years ago. So the way the device development go through development phases. First, you know, obviously the company or some researcher makes a prototype in the computer, right? And then once that prototype seems to be working okay in the laboratory, then the next step is to test the device in the animal lab, which is where essentially the surgeon need to help because it's a real surgery. And then the surgeon, the clinical team actually need to demonstrate some feasibility, safety in the animal model. And then once that data is submitted to the FDA, and then they approve the trial of the prototype device in human, then the clinical trial starts. So for example, the device we currently working in the clinical trial was tested by us in the laboratory. And then the next, the candidate device, which I showed, is the essentially undergoing the animal trial phase right now. We received the national federal funding as a essentially primary investigator. So that's what the TCH is the leading. So once we get the animal data, then the next phase will be a clinical trial. Yeah. So TCH is really deeply involved. But to be honest, any pediatric potential candidate, the company will come to TCH for the testing.
Very good, very good. Well, we are at about time here, so I would like to thank everybody for joining the call today, and particularly Dr. Dreyer and Adachi and Calderon and Penny for being with us today. I also want to encourage you, if you have any topics that you would like to have discussed during one of these future calls, please feel free to reach out to your contact at the Office of Philanthropy. That can be a hard word to say sometimes. And any of the folks here on the call, the doctors would be excited to speak about their work with you. So thank you again for your interest and support of the Heart Center, and have a wonderful rest of the day.
Thank you.
Everyone.
Thank you.